conference is now being recorded.
Welcome to the AMDA webinar, Diaphragm Delivery of Recombinant Adeno-Associated Virus Acid Alpha-Glucosidase Gene Vector in Patients with Pompe disease. Your guest speaker for today's program is Barry J. Byrne, MD, PhD. Dr. Byrne is the Associate Chair for Research, Department of Pediatric, Microbiology, and Molecular Genetics, and he is also the Director of the Powell Gene Therapy Center at the University of Florida. The AMDA is buying a copy of today's presentation, and it will be posted onto the AMDA website if you are interested in listening to the information presented during this webinar at a later date. Operator assistance is available at any time during this conference by pressing £0. A question and answer session will follow the presentation. You may send chat questions at any time during the presentation. The chat window indicated by a speech bubble icon located to the right of the presentation. I will now turn the call over to our speaker. Dr. Byrne, please begin.
Hi, thank you very much. And I'm glad to provide an update for the group on the status of our gene therapy trial. The simpler title of this talk would be Strategies for Treatment of Pompe disease and a gene therapy update. So I think a lot of people on the call already are aware that the Pompe disease spectrum includes both skeletal myopathy as well as cardiac abnormalities in particularly the youngest patients. We now know, though, that a greater proportion than anticipated of those patients with early heart disease and muscle weakness ultimately develop respiratory failure. And that is the principal focus of this trial because our studies in animals have revealed that the cause of this respiratory difficulty is related to the nerve function that controls respiration. And so this spectrum of disease now goes beyond just the muscle components, but the respiratory problems that are influenced by nerve function. So the mutations in the gene for acid alpha-glucosidase, or GAA, lead to Pompe, and the principal cause of the problems across the age spectrum from the earliest presenting patients to ones that are only detected in adulthood is the accumulation of glycogen within cells, leading to cardiac problems, difficulty with feeding, and also speech and hearing. We know a lot about the respiratory, the musculoskeletal problems, but also the respiratory problems are one of the biggest challenges for the patient population currently. This schematic of the muscle cell helps explain some of the aspects of weakness, and certainly we know that membrane-bound glycogen in the lysosome is the real culprit, causing a loss of muscle fibers. And you can see in the affected muscle cell on the right the loss of muscle fibers, which ultimately results in weakness. And these lysosomes are occupying a lot of the space inside these long muscle cells. And when there is not enough space in the cell to build new muscle, there is weakness. One of the controversies that exists now in the field is how much of the early problems ultimately become irreversible problems. And this shows a concept about the progression of disease in which the muscle architecture is relatively normal early, but we know also from mouse studies that glycogen accumulates even before birth. So even though the late changes are not present, we know that since this is an inherited disease, that every cell is affected from the time the embryo first begins to form, And the real unanswered questions now is, in this process, how much of this damage that happens within the muscle is reversible. And that certainly in later disease, that many of the muscle fibers are not functioning normally. And this ability to regenerate new muscle fibers or reverse the glycogen accumulation is one of the key questions that is pushing us towards earlier treatment and to improve outcome long term. So there are really three important areas of study for treatment in Pompe disease. Some of those are very early phase research activities, and some have met significant accomplishments in the clinic. Certainly everyone is familiar with the enzyme replacement studies. Two of those have had the most relevance for the approval of Myozyme, 1602 and 1702 studies, and I'll talk a little bit about those and not much about the LOT study, which I'm sure you're all familiar with. And then a new compound that was initiated, the work in this area initiated by Zystor Therapeutics, now a joint project or a project of BioMarin. So this compound is now being called BMN 701, is an alternative to the conventional enzyme replacement with a goal of targeting the protein in a different way to cells and in an attempt to further improve the efficacy of ERT. The gene therapy studies rely on supplying a functional gene for the enzyme, so allowing each muscle cell and each nerve cell to make the Myozyme itself. There are a number of theoretical advantages to this strategy, aside from the fact that in all the studies we've done thus far, at least in animals and in a number of studies done in humans, the vehicle we're using to deliver that gene results in very long-lasting effects of the gene, and there is essentially the concept currently is that for most muscle diseases this would be a single-dose therapy, that the treatment would last for as long as the life of the cell. So the third opportunity is to change the way proteins fold, and this would be relevant for a certain group of mutations, or possibly even the way enzyme replacement therapy functions in the circulation, and the stabilization of enzyme with chaperones is another consideration. And all of these approaches can work together. And I think one of the important concepts I want to try to emphasize is the notion that combination therapies make sense in many different areas of medicine, in infectious disease or in oncology, and I think we need to bring that same approach into treatments for Pompe disease. So I'll just start by emphasizing the important results of the pivotal studies of Myozyme. The really significance of this trial shouldn't be underestimated, because it really, as many of the participants know, is really the first definitive impact on the early presenting disease patient population, where we had important comparisons to historical cohort. And in many rare disease studies, that critical information is necessary so that it avoids the need to do a double-blind type of study design. So as an open-label study, the significant difference between the control population shown here, and where only 1 out of 62 untreated control patients from a slightly earlier era would have been alive at this age. All of the trial participants were alive after 1 year of enzyme replacement therapy. And I'm going to try to explain why there was a survival benefit in the patients on treatment and what we learned from that treatment population that's led to the current gene therapy study. So to try to keep the focus on why gene therapy for this condition. This was not the primary outcome measure of the study, though. Really the most important focus of the study is to pick the outcome that one's going to study most carefully. And the primary outcome measure for the 1602 trial was ventilator-free survival. So let me explain why we think there was an improvement to the point at which there were all of the patients surviving compared to that historical cohort. When we look at all of the patients in 1602 and 1702 together, that's a total of 38 subjects which were analyzed long-term. The group that started the study without a ventilator was divided roughly in half by those that became ventilator dependent and those remained free of assisted ventilation. And of the 17 that after a little more than a year of long-term follow-up were not ventilator dependent, 16 of those were alive and ventilator-free at the end of this additional study that was done for longer-term follow-up of these two patient populations. So if we analyze the cardiac data based on that outcome, in which the group A were those that are alive and group B had either progressed to assisted ventilation, we see some striking differences between the groups rather than analyzing them as a single collection of patients. And the key difference between the two groups shown here, one in the square boxes with the red line, are those that had either died or went on to ventilatory assistance, or the group that was alive and not receiving ventilatory assistance. This looks at the left ventricular mass, or the weight of the left ventricle, relative to normal. And normal would be a value here at 0 z-score, so that's the average. So you can see how strikingly above average the patients who were not ventilated compared to those that ultimately required assisted ventilation. And so this is very significant. And another measure of that is not the mass alone, but how dilated the heart was, or the mass to volume ratio. Again, distinctly different between the two groups. When we look at whether the patients received infusions between the started Myozyme between 0 and 11 months or greater than 12 months, there was not a significant difference in the LV mass or the mass to volume ratio. This is important for a couple of reasons. One is it suggests that even in slightly older patients, there's reversibility. You see that the same degree of reduction in LV mass was achieved in the patients with early infusion as compared to those with later infusion. This may be a function also of their underlying mutation, but suggests that in both groups there was reversibility of this increased mass. And I can summarize those brief overview of the cardiac findings this way. There were EKG changes in the PR interval. It's one of the recordings done in the EKG tracing that changed, improved with ERT. I didn't cover that. The left ventricular mass improves with the fact that some can be predicted to be minimal responders, and we saw that in an analysis that was done by group looking particularly at ventilatory function. And that the improvement in ejection fraction is another subtle change that depends on certain baseline characteristics, and that overall the survival data reflect the improvement in cardiac function. But we know very little, actually, about whether the degree of functional improvement allows the children to have much functional reserve. That is, are they going to grow well as they get larger? Will cardiac function continue to keep pace with their increased body size? And does the heart function normally when it relaxes? We looked only at systolic function or the contractile function during the part when the heart is pumping blood out of the heart. When the heart is pumping blood in, this is an important aspect of heart function that controls and somewhat influences respiratory function because the blood in the lungs needs to return to the heart. So those are the key aspects of the cardiac component of the study that I think influenced survival. But yet, as I mentioned, survival alone was not the primary outcome of the study. Ventilator-free survival was. So this is freedom from invasive ventilation. And you can see that 3 of the 18 patients went on to require invasive ventilation, and that moreover any type of ventilatory assistance was even at 18 months of age was required in 6 of the 18 patients, and that we know that at longer time points after this 18 months that additional patients lost the ability to breathe independently. So that was one of the principal causes for us to go back to the mouse model. Of course, not everyone knows we have to protect the identity of mice just like patients now. And we did some additional studies in the mouse that analyzed the function of the respiratory system. And particularly, we're interested in whether we could train the mice through some specific testing to get stronger. And it's hard to get mice to lift weights, but we figured out how to do that. The ventilatory function that we test is very much like when you go for a pulmonary function test, except there are a few of the measurements rely just on the mouse's ability to breathe quietly. So we assess the mice by this protocol, which measures both the rate of breathing, the frequency, the volume of breathing, the tidal volume, their minute ventilation, or the product of these two, and their flow rates. The way we challenge the mice to breathe more forcefully is with a stimulus, and in this case the stimulus is high CO2, and the high CO2 is brought into the breathing chamber after 60 minutes of normal air. The increased CO2 causes changes in the tidal volume and frequency of the ventilation that we can measure in terms of minute ventilation. So I'm going to show you the result of challenging the Pompe mice to breathe faster in response to CO2. So this is a graph of minute ventilation versus time. And we found that the response to the challenge of ventilation is very blunted in the Pompe animals. So this dotted line is where the CO2 challenge has begun, and you can see that in a normal mouse, they go from breathing about 75 mils per minute to more than doubling that value very quickly over several minutes. In the Pompe animals, there's almost no response initially, and then there's a very slow response, but also a very inadequate one. So they start off at about half normal, as many people are aware their pulmonary function tests are about 40 to 50% of predicted. Same is true of the mice, and that they don't respond to a challenge. And challenges come in many different ways. For a child, that may even just be a respiratory infection or a fever. Doesn't mean that CO2 is the only challenge. Anything that causes us to need to increase ventilation is a problem in the children. So a little bit about the control of breathing, a whole fascinating area of research in which we know that the brain itself is responsible for controlling respiration, but the signals from the brain and the brain stem have to travel down the spinal cord, and this is a small section of the spinal cord showing where the ventral horn or anterior cells that control breathing come from. And the way this works is that the cells in this region of the spinal cord travel out through the spinal nerve, and in the case of the diaphragm, all of these originate in the part of the spine called the cervical spine. And those regions in the cervical spine that control breathing give rise to something called the phrenic nerve. And we can measure phrenic nerve function directly in mice, and we can also learn a little bit about the composition of the spinal cord itself, and that's what this study represents, the amount of glycogen in the spinal cord as a function of age. So early mice with Pompe disease have about twice as much spinal cord glycogen as control animals, and you can see that this gets worse as the animals get older. So a mouse lives to about 24 months of age, and these older mice have significant levels of glycogen accumulation in the spinal cord. So that suggested we needed to look more carefully at the spinal cord function, and particularly the phrenic nerve function, and keep in mind that this amount of glycogen is in the whole spinal cord. The amount that's just in the area where the nerve cells arise is even substantially higher. This is a little bit of a complicated slide, but not focusing too much on the bottom part, but on the top part. Just suffice it to say that the amount of output that is the driving force for breathing that's coming from the phrenic nerve here is about 50 in the normal mice, and about 1/10 of that in 2 different mouse strains where we can study the effect of nerve function on breathing. In fact, this mouse strain right here, shown by the hatched bar, has completely normal muscle. The gene for GAA has been replaced in every muscle cell of this mouse line except in the brain and spinal cord. So even in the presence of normal GAA activity in muscle, we know that the activity of the spinal nerve that controls breathing, the phrenic nerve, is deficient, and sufficiently so that those mice, even with normal muscle function, do not have normal breathing. So that gets us now to what can we do about that. The thing that is unique about the spinal cord and the brain is they're protected from the circulation by something called the blood-brain barrier. And that's why enzyme replacement therapy and possibly even other forms of drug therapy may not reach the spinal cord and the brain. We know now from a series of studies done in our lab and also related to the problem of spinal muscular atrophy and ALS, another spinal cord disease, that AAV vectors, the same ones that we've been studying for use in muscle, also travel to the spinal cord. So we know what the gene is that needs to be delivered. We know that it can be given one time in muscle and persist, and that's also true in in neural tissue. We have the best information about that from studies done in a form of inherited blindness called Leber's congenital amaurosis that we now have up to 3 years of follow-up data in patients who've had treatments in the eye for this form of blindness, and that the effects persist for an extended period. I won't get into the issues about how the protein's processed in much detail unless there are questions about that, but we know that the most efficient way to get GAA into the lysosome is from the cell that contains that lysosome making the GAA itself. That's the way the system was designed to work. The concept of DRT is kind of a workaround that normal system, and by putting the gene back in the cell, the hope is that it will process normally. And then lastly, the potential to get the gene into motor neurons is one of the goals of the study. I'll say a little bit about the way this is going to be done is with an AAV vector. This stands for Adeno-Associated virus. It's a type of a virus that has been engineered to carry only a therapeutic gene and none of its original viral genes. This concept was actually developed by a group of scientists at the University of Florida back in the 1980s. Then in the mid-90s, while I was in Baltimore, we showed that this concept can work long-term in muscle cells. So based on the vector technology that was developed at Florida, and we have used this simple design shown here in which a very strong promoter makes the muscle cell express the gene in this DNA, which is delivered to the cell through the virus. I want to show you some proof of concept studies just to give you an idea of how profound the effect is when the gene is delivered to the spinal cord or to the neural tissue, and what the long-term consequences are, we hope, in the patients. So I'm going to start by looking at the middle panel. This is an actual picture of the spinal cord like the one that showed you earlier. This is the front part of that area in the spinal cord that carries the cells that drive the diaphragm function. You can see in areas where the gene was not delivered that these positive pink cells contain glycogen. But in the area that was where the gene was delivered, the cells appear more normal. And in fact, when we stain with an antibody for GAA itself, we can find that the gene transfer has worked and is expressing the protein in those cells. And if we look at the activity of the enzyme in those parts of the spinal cord, here's the normal activity level in two different parts of the spinal cord in unaffected mice, and that when we look in those two parts of the spinal cord in control animals, shown in the middle here, ones that got a green fluorescent protein virus, you can see they're both low in the knockouts. But in the animals that were dosed with AAV in the region that leads to the cervical cord that controls breathing, the activity levels are essentially normal, and that there's a small amount of the protein that goes to a lower part of the spinal cord as measured by the activity assay. And if we measure breathing in those animals, the ones that got the control virus are shown here in the green circles, the GFP virus, that's right here. They continue to lose minute ventilation as they get older, and the ones that got the therapeutic vector, the exact vector that's being used in the clinical trial, had breathing rates and breathing function that almost matched. In fact, it was the average was a little higher than the control animals. And there were also problems with the breathing rate. Is something really easy to measure. the respiratory rate, we can see that in the treated animals, they had breathing rates that were much more similar to the control mice than the ones that got the GFP vector. Another way of looking at that breathing rate information is a little easier to compare. The control mice have very regular breathing. That means they all seem to be breathing at about the same rate, and you can see that the GAA animals are all spread out. They all breathe at different rates, some very slow, some very fast. This kind of reflects the fact that the control of breathing is altered in those animals. So now to the gene therapy information. So that's the issues related to breathing, but we also know that vectors delivered systemically, and this is the ultimate goal, will lead to correction of the heart problems that I explained initially. So the vectors are not only for breathing, but may influence heart function. Here we've compared the effect on the heart size in animals that receive Myozyme or those that received AAV vectors that are made from two different kinds of promoters, one that's specific for muscle and one that's expressed in all cells. So we think that this approach is not just for breathing, but also for heart function. So I'm going to take a minute to summarize the animal model studies. That certainly the mice have a lot of features of Pompe patients, both in their heart function, respiratory function, and skeletal muscle, and that when we put back the GAA activity, glycogen is eliminated, and then we can measure how that influences both heart function or breathing function, or the so-called physiologic correction, and that we think is the best way to predict what might happen in the clinic. And that for breathing function, it's this combination of muscle weakness and neural pathology that are responsible for ventilatory failure in the patients, and that's one of the objectives of the study. So as I go on to the trial, I'd like to take a minute to see if there's any questions, if you wanted to type them in or through Marcia ask any questions, or I can continue.
Ladies and gentlemen, at this time we will conduct the question and answer session. If you would like to ask a question, please press 7# on your phone now, and you will be placed in the queue in the order received. Please listen for your name or location to be announced, and be prepared to ask your question when prompted. You may also send chat questions in the chat window to the right of the presentation.
Okay, so no one has a burning question now. We can keep going.
Dr. Byrne?
Yes.
I have a question from George Fox.
Hello, George.
Hi, Barry. Thanks for having this presentation. I wasn't sure if anybody else was going to chime in.
We can always count on you, George.
Question-wise, well, I just had really one question for now. I'll probably have another one in a little bit here. And I don't know if my question is actually fair or answerable, but I don't know of anyone else in the world who would be better equipped to answer it. And you're talking about the neurological deficit in Pompe disease. And my question is how do you think that translates to the Pompe population as far as the percentages of folks with Pompe that actually have neurological involvement? Is it all, or is it a percentage?
No, it's a very good question, and until we do direct measurements that evaluate this aspect in patients, and certainly in the young patients and in the older patients, we now have the capability to measure the contribution of this part versus the muscle part. And, you know, one of the biggest challenges, I'll be very frank about it, is that the kind of conventional wisdom is Pompe disease is a muscle disease. And I think it certainly is a muscle disease, but we shouldn't be surprised that there are other factors that influence the function of muscle. And we know in every other lysosomal storage disease that there are some neurological components, some that have a big impact on cognitive function. Luckily, that's not the problem in Pompe disease. We know that all the patients do quite well in school and in life with cognitive function. But we can use the respiratory system to understand this better because the standard approach to measuring respiratory function allows us to be very precise in a small number of subjects. Honestly, most of the studies that have been conducted thus far is that for rare disease have relatively small subject populations. So in order to get definitive answers from clinical research projects like this, we need the most clear-cut outcome measures that are possible, and that's one of the reasons we focused on respiratory function. And so what I would have said is a small part previously, based on our current studies, suggests to me that this aspect is a much larger part of the problem than we had ever anticipated. And this is essentially a new natural history of the disease in the treated patient population. We would have never observed these abnormalities given the early fatality related to the heart problem. So the heart problems are improved, and that then uncovers another layer, which we think we can do something to manage it in this way if we can get the right levels of the enzyme made in the central nervous system.
Okay, well, great. Thanks.
So maybe that's a good segue to explain how that might be accomplished. And so this process has been a lengthy one, as you can imagine, because of the regulatory oversight that I think helps protect patient safety is an important part of our system. So we have to be sure that these ideas are fully vetted before the regulatory authorities and that the science makes sense. So actually in 2005, we first applied for funding related to this project, presented it to the Recombinant DNA Advisory Committee in September of 2008, and then in consultation with the FDA, performed a series of preclinical studies that allowed us to assess the safety of gene transfer using this vector by the intended route in a clinically relevant model. And I'll show you some of that, and then that led to the study design that we now have full approval for. Just briefly to say what the aims of an early phase study are, to first of all look at a very specific population. We knew from a number of studies that IM administration of AAV serotype 1 had a very favorable safety profile, but we are interested in a group of patients which have one of the most urgent needs, probably the most life-threatening consequence outside of the early heart disease in the patient population. Again, if we take the notion that we can manage some of that with Myozyme, then what part of the overall care is missing? It's to achieve more independent ventilation, greater safety related to ventilation. So the study, as an early phase study, is designed to look at the biodistribution. That means where does this gene vector go when it's delivered into the intended site, and then is there an immune response to that form of GAA? And then secondarily, we'll see whether there's an effective dose on pulmonary function. And of course, there are challenges in measuring pulmonary function and neural function in children this age, but we think we have many of those assays figured out. There are two dosing groups in the study. It's what's called an open label study. That means everyone enrolled who is eligible for dosing will receive the active study agent. There's no placebo group. It's at a single site, although we're hoping to be able to expand the study to Europe for participants in the EU because of the difficulty of travel to the U.S. And that the way the vector is delivered is by an intramuscular injection, just like has been done for the Duchenne and limb-girdle trials, as well as the study we've done with alpha-1 antitrypsin deficiency. And the only difference being that to reach the diaphragm reliably and to assure that all the dose is delivered to the very thin muscle of the diaphragm, this will be aided by direct vision. In some ways, this gives us more control and safety than the blinded type injections that have been done in the other studies, with a very minimally invasive approach in which there's about a 4 millimeter incision placed on each side in order to watch the injection take place. Initially, we have approval for 6 subjects to be dosed and 10 to be enrolled. To be included, the patients have to be older than 3 and under 16 years of age. And the reason for that is we wanted to be sure that anyone who had early ventilatory failure had sufficient efforts to try to reverse that process and see if they could breathe independently, and that there wouldn't be any expectation that those patients would have sufficient improvement with longer treatment of Myozyme to become off the ventilator. So, and then the age of 16 is somewhat arbitrary in that there are not many patients in that age group that are have either juvenile onset disease with ventilatory failure, and certainly there are very few patients with early onset disease that are beyond the age of 8, frankly, because that was about when the Myozyme study started. So one must have a genotype consistent with Pompe's disease and have GAA deficiency is a must-have invasive ventilation because that allows us to most carefully measure ventilatory function and then and able to participate in long-term follow-up. Patients who can't be in the study might have abnormal laboratory results, bleeding tendencies, including platelet dysfunction, beyond other investigational drugs, or have had a history of viral infection. And but we think that most of the patients who have initially responded and interested in the trial would qualify. The rough study outline is shown here. It actually continues enzyme replacement therapy throughout the study. The patients up to, in fact, 3 months before the study starts will also get a period of inspiratory muscle strength training, which is something I can talk about more, but it provides the best opportunity to see whether there's any ventilator-induced dysfunction that can be reversed. So we know from adult patients and a little bit of data in children that the ventilator itself can be very detrimental to diaphragm function, and even in a matter of days and weeks. And so there's going to be a lot of effort put towards optimizing diaphragm function prior to initiating the study, and that'll be done prior to dosing of the vector. So I hope there's maybe now we can open up to more Q&A, because I just want to summarize by saying we know this continuum of disease is all due to glycogen accumulation and the degree of glycogen accumulation. Obviously, early diagnosis is important to optimize management, but I do think that some of the changes, and this may be distinct in Pompe disease from other muscular dystrophies, some of these early changes are reversible. Of course, it requires a big team of participants, And I think after these pivotal studies of ERT have been completed, we really need to think about what's next. And so these next generation therapies, whether it's another ERT or a chaperone, or in this case, a gene therapy study, and maybe all used together, can benefit the patients the most. And there are a lot of people to acknowledge, certainly the work supported by Genzyme and all the investigators in the Genzyme studies, the key contributions from the NIH group, Nina Rabin and Paul Plotz. Those at Children's Hospital helped do the analysis of the cardiac work, and then our group here at Florida listed there, and both specifically Catherine Ma and David Fuller, and for the clinical trial that I just described, Leanne Lawson has been phenomenal in getting us from 2005 to now, and all of the funding agencies that support it. And here's contact information for Leanne, who is the point person for the trial, or is explained on clinicaltrials.gov. And I think for you, George, I have to show that some of the patients are even Gator fans, even when they're not in an off season like this year. So let me take questions now, and either through the phone or on the email part.
Again, if you would like to ask a question, please press 7# on your phone now, and you will be placed in the queue in the order received.
So I could read a couple of the questions one of them is to the group by Brian White. It says, how do you bring a product to market like this with only one treatment? So meaning, I guess, single dose delivery of a gene therapy product is what Brian's referring to. That is, of course, an interesting question. The concept of market approval of a biologic like this has been studied by a number of groups, and Genzyme as well. There are strategies that have been proposed, and is, I think it's kind of really coming to light in the last month. There is a lot of interest in rare disease treatments from large pharma, and I think, this Brian points out, this is very different than the conventional treatment of a disease with a pill or a small molecule. If this strategy in fact works, this might fall under the category of more of a curative treatment than something that requires repeat or daily administration, or every 2 weeks like Myozyme. And I'm sure that the financial people will figure that out. I think I try not to worry about those issues, although it is worth bringing up, because without a product, no therapy, whether it's a tablet or a biologic therapy, will ever be provided long-term to patients. It just there has to be a model by which it will be available through the regulatory, go through the regulatory process and be available long-term. So it is a real concern, but I hope that the people within industry that understand those issues better will figure out a model. And there's certainly lots of interest lately, because conventional medicines are going to comprise a smaller and smaller portion of the portfolio of even large pharma companies, and that's why we see a lot of activity in that area of large pharma getting involved in biotechnology and biologics research like this. Monique has a question. It says, because the spinal cord and brain are protected, does this mean ERT drugs are not getting to those areas? Yes, that's exactly the case. This was engineered into our systems to protect a very vulnerable closed space like the brain and spinal cord from infections in particular, and to change, and there's a very unique environment of the brain and the spinal cord and the fluid that surrounds it to also protect it from trauma. So that's why it's encased within the bone and spinal cord, and that those two systems help us maintain integrity of the brain and spinal cord, but also prevent many drugs from reaching there. This is an exact issue also faced in neuro-oncology and treating brain tumors. Many drugs do not penetrate the brain, and in fact have to be put directly into the spinal column to provide treatments for those conditions. So this is not a new thing in medicine, and I think that the unique feature of the viruses that travel up the nerves from muscle into the spinal cord is a way to access this space as opposed to direct procedures on the brain or spinal cord. Although those have been done, I should maybe comment that Dr. Paul Hu in Taiwan, who's been a leading Pompe researcher, is also doing a study in infants with a severe enzyme deficiency called AADC deficiency. Aromatic amino acid decarboxylase is one of the same enzymes that's considered as a therapeutic option in Parkinson's disease, and these infants have a lot of symptoms similar to Parkinson's disease, and in fact he's been successful in delivering the same gene transfer strategy but delivering directly to the brain. This has also been done in a group of patients with Batten's disease by Ron Crystal in New York. And there have been studies in Parkinson's patients themselves now, in phase 2 studies in the clinic that have shown safety and some efficacy in Parkinson's disease. And the other example is, as I mentioned earlier, in the eye, where the vectors that we deliver for these LCA studies done at Florida and at UPenn is in the back part of the eye, under the retina, which is essentially a part of the visual pathway that connects to the brain. So there are a lot of examples of where this can be done. And so then, are there hearing problems in some Pompe patients, and do they seem to be neurological? That's a very good question also. Yes, the hearing information that was obtained as part of the pivotal studies was very informative in that we knew that there were some conductive hearing losses that relate to the way the middle ear works and the eustachian tubes that connect into the back part of the pharynx. Those may not be all explain all of the hearing deficits. The studies as part of those the ERT studies was done as a safety measurement, but there have been subsequent studies done in the mouse model that do suggest that some of the hair cells that are part of the nervous system, essentially, in the Pompe mouse, have deficits that could be are believed to be related to the dysfunction of those hair cells from glycogen accumulation, and those are the ones that are responsible for transmitting hearing signals into the brain. So they're probably not problems in the analysis part of the brain, but yes, maybe out in the inner ear. There, some of the hearing deficits may be related to neurological problems. And Matt Crowley has a question. If this begins a successful treatment, do you see it someday expanding to patients who, with a milder form of Pompe, who do not currently use ventilators? So also a great question. Obviously, we want to minimize risk in the procedure, and in fact, we anticipate these first 6 patients which use the existing method of intramuscular injection will be the only ones that require intramuscular injection, and in fact a lower risk procedure, much like getting a catheter placed for an IV or like one of the infusions would be the method used to try to impact on diaphragm and respiratory muscle function. We have to keep in mind the diaphragm normally at rest supplies most of the breathing function, but there are other muscles, the extra diaphragmatic muscles, that also participate in breathing, all those that help lift the shoulders and are between the ribs and the rib cage participate in respiration. And what seems to happen in Pompe patients is that their roles are flipped over and that the extra diaphragmatic muscles start to work sooner than in other individuals, and that so we think that it's not just the diaphragm and the phrenic nerve, but the other muscles in respiration might benefit if we gave the gene transfer in the whole space around the lungs and in the body wall. And so that method of delivery is going to require a more efficient vector, which we've already developed, and we are now beginning the regulatory process of moving to the next step. So what will be a lower risk delivery procedure, and that may be justified in patients who have some breathing deficits but are not using a ventilator. So that would be answer to Matt's question. And Tiffany posted a question, says, to clarify, this approach will only target one respiratory system. Only targets the respiratory system, and will combination ERT still be necessary for the rest? Yeah, ERT is our best approach to and the most efficient way of delivering it, whether with either the new enzymes that are coming available or Myozyme. The best way to get the benefit that's achievable now in the large muscle mass that exists outside of the body. I think we have a long way to go from very local therapies, as in the muscular dystrophy trials, these were focused on one muscle. In the limb-girdle study, which is really the first successful gene therapy trial in muscular dystrophy that we published in 2 months ago, it was just a single muscle in the foot, and that a non-essential muscle that could be biopsied and studied. And so the idea is to go from that very local treatment to a regional treatment, and then with enough safety demonstrated in those methods to go to systemic treatments. But one of the barriers that have not, frankly, been really managed effectively is how to get enough material. Almost the very same problem that plagued the early phases of the enzyme development. The studies in part were done in infants because that was the availability of the drug, and so manufacturing these vectors is every bit as difficult as making large-scale Myozyme, in fact. So going to systemic treatments is going to honestly take a while, but that's the long-term goal. So that's kind of the answer to Tiffany's question. So the Dunlaps. Hi, Julie and John. How are you? Because the spinal cord is protected, should we expect to see respiratory issues with treated patients? So it does. That answer to that question kind of depends on how much residual activity there is in the spinal cord tissue and in the other muscles, and that I think that some of it can be overcome. We know that even patients with very little diaphragm function can develop enough strength in their other muscles that they can compensate somewhat. But the diaphragm is normally, and the whole respiratory system is so well developed that it compensates for a huge amount of activity that we might be doing. So yeah, at rest there may be enough compensation, but certainly with colds or exercise or other stressors on the system, there may not be enough functional reserve. And so ultimately, with the right challenge, we can uncover the deficiencies. And so it's just a matter of when do those, for any given child, become a clinical problem. So I do think that if we use the right measurement, we could find these problems even very early on in people who appear to be breathing normally. Crystal Hayes said that first, my understanding is that if clinical trials go as anticipated, those on ventilator will be able to reduce their time on the ventilator, and also the hopes that they will be ventilator free. So that's an excellent question, because that is the ultimate goal. Of course, I mentioned a little bit the inspiratory muscle strength training. Maybe I should bring that up again. Adult patients who become dependent on the ventilator for a variety of reasons, whether it's trauma, surgical intervention. There's very excellent information now by a group here. In fact, Danny Martin and Barb Smith have pioneered a lot of that work to understand what's required to train people to breathe spontaneously again in adults. And we've coaxed them into working with our Pompe population to use the same strategy to try to see what their optimal diaphragm function is. So that's why we're including a period of training prior to dosing to see what the real baseline is, and that is something that I think can be done in a number of patients. Sometimes one that has really reasonable function can improve to a point of maybe not being completely ventilator free, but having a little safety margin or ability to get some additional diaphragm function, particularly when you're awake and upright. I know that many patients are probably aware that lying down puts a lot of additional load on the diaphragm. It makes breathing very difficult, particularly in the adults and in the children. And so that's a good question. And then the last part of her question is, would this be given to those with infantile onset that are not on ventilators in hopes of preventing the need for one? Yes, I think we know now, again, based on mutation, those patients that are very likely, and this was the majority of the patients ultimately in the pivotal studies, went on to need the ventilator or have some deficits in ventilation. So yes, preventative treatments are, I think, always going to be preferred, and that would be the long-term goal if we demonstrate safety in this small group of patients. And then would respiratory training take place before travel to Florida was a question. That's a possibility. We're trying to enable that by doing two separate studies. Some studies in which patients would receive only the respiratory training, and that could be for any length of time before participating in the dosing study. And so it's required in the dosing study. It can be done independently. They're not exclusive trials, and because we really consider this kind of rehabilitation to be standard of care in many cases, and a main reason we're doing it as a study protocol is so that we can carefully measure the improvements if they happen from baseline to different every month. We'd be assessing the response. And then the last question is, will this work for CRIM positive and CRIM negative patients? Yes. That is a unique feature of going inside the cell itself. We anticipate that many of the patients in this trial will be, in fact, CRIM negative. Are there any other questions that I can answer?
Dr. Byrne, we show no more live questions.
All right, if there are no more questions, I guess we'll conclude here, and thank you all for participating, and be happy to talk with anyone else offline or communicate with Leanne by email. And we really appreciate all the support of the AMDA and the interest in the study and trying to help out all the patients who are out there facing these challenges. So appreciate all your courage and efforts to help move to the next step.
This concludes today's AMDA Acid Maltase Deficiency Association webinar. Thank you for attending.
Thank you, Dr. Byrne.
Thank you.
I appreciate it. It was very interesting.
Okay, well, I'm glad you enjoyed.
The moderator has ended the conference. Goodbye. Thank you for calling.